Hello, I'm Dr. John Kruse, and welcome to this week's question and answer hour, where I'll try to answer questions based on the video I released this past week, also on other ADHD topics, and even more broadly on general mental health. As usual, the comments I'm saying here are intended for informational purposes, not direct recommendations or prescriptions. So take this information back to your providers as needed. And any other, there is a associated subreddit. So if writing questions or comments here or on the YouTube channel is not the best format for you, that's another way to enter this discussion or continue this discussion. And I don't think there's any other announcements or warnings, so I'll just jump into the questions. Hopefully Elon Musk and Starlink will behave for this hour. So hello, Dylan. Again, Dylan asks, is guanfacine effective for ADHD-PI? So inattentive type bias or primarily inattentive ADHD. So the research would suggest that guanfacine is effective for inattentive symptoms and therefore is effective and can be helpful for individuals who have primarily inattentive ADHD, whether it's the most logical first choice for a given individual. I'd say that depends on lots of factors, which I won't know which are pertinent, but so yes, it can be helpful. It may not be the first choice someone thinks of, particularly given that it isn't activating and can be sedating. So, I forgot to summarize the video. So I'll jump backwards and summarize the video. So the video I released was about rules that the DEA has proposed will be official at the end of the year. And to put this in context, there was relaxation of telehealth rules in the beginning, spring of 2020, when COVID struck. And magically, so I'll back up even more. For more than 2 decades, Medicare and other government entities have been trying to promote in the US telehealth use, and they were frustrated at how low the acceptance and participation rates were. And one of the big factors was the requirement at that time that not only a patient calling in, was going to use specific software designated for it, which wasn't widely available, but the requirements also included that they go to a specific location, usually their local clinic, to dial in to their provider, either in the big city or even in that hospital. And that was one of the restrictions that was immediately relaxed during COVID. And they were surprised that, wow, people can call in from their own house using pretty much any software they want. And that was a major contributor to skyrocketing use of telehealth. So in the US, the medical emergency for COVID-related was declared officially over in May of 2023. And there have been at least 3 times since then that the DEA has proposed rules or regulations or changes, some of them reverting back to pre-COVID, some with new onerous restrictions. There's been pushback before, but they've indicated they're not going to keep delaying what's going to happen. They've already have instituted some new rules for buprenorphine prescribing. That's a opioid partial agonist that's used for opioid addiction treatment. Anyway, the new DEA rules, again, these are not official yet, but they haven't indicated they're backing off from them. One is that before prescribing to a new patient controlled substances, a doctor would have to have a in-person face-to-face visit with them. So if you saw your doctor once 14 years ago, just once live, then they are grandfathered in and you don't need to see them again live before you start prescribing. So I'll back up and say the DEA has explicitly said they are concerned about a stimulant epidemic following the opioid epidemic. Stimulants in combination with opioids have become the largest component of the current opioid epidemic, which certainly has stopped growing and overall might be waning. Um, and they have specifically said that they are targeting online, purely online telehealth centers, particularly those claiming to be treating ADHD. They're specifically targeting that business model in an attempt to reduce or minimize a stimulant epidemic. So, so one rule is an in-person evaluation for new prescribing of stimulants. The second is that any doctor prescribing any stimulant, any controlled medications, so that would be stimulants, benzodiazepines, opioids, would need to get a new license costing $888. The initial proposal was they would need a new license in each and every state, although there's been some indication that maybe there would be some reduced rate for multiple state licenses. Thirdly, beyond the just any controlled substance prescribing, any doctor who wanted to prescribe Schedule II substances would need another special, additional, more restrictive license. Um, in addition to the cost of the license, there's almost certainly going to be required mandatory training, which is usually only offered through pay for services that provide it. So we're talking probably a few $1,000s for each license. And to clarify, in the US, Schedule I substances are those deemed so dangerous and risky without any medical value, which would include still psilocybin and marijuana and LSD. Schedule II are substances which high potential for abuse, so Adderall, amphetamine products, methylphenidate products, many of the opioids. Schedule 3, 4, 5 are less restricted based on a perceived less risk of abuse, and many substances are not on a schedule at all. So blood pressure medications, diabetes medications are unscheduled. So furthermore, the DEA is going to impose new regulations and rules for any telehealth company. Now, what's not at all clear is an individual provider considered a telehealth company if all they're doing is working remotely, as many psychiatrists and other physicians have started doing since COVID? Um, and there would be the DEA would be in the position of deciding whether this entity is providing quote essential services or not. The DEA has not spelled out what criteria they would be using, but they would get to decide. And if it wasn't essential, they could forbid it. And then furthermore, there would be even doctors who had these licenses could not prescribe more than 50% of their controlled substances prescriptions via telehealth. So at least half of their prescriptions would have to be done in face-to-face live presentations, which I'm working completely remotely in Hawaii. That would make my practice impossible. And finally, they would be clamping down on across state prescribing. Again, they made some provision, though, for being licensed in multiple states, and it's not completely clear whether they really expect these doctors who are licensed in multiple states will actually be traveling back and forth between all those states or doing some of it remotely. So that's the talk, or that's the proposed regulations. It's possible none of those will be enacted. It's possible they'll be delayed further. It's possible even more severe rules will be enacted. And Brian Buksinski, and hello, we've emailed and I've seen you commented before, so it's good to have you live. He asked, would the new DE rules, if implemented, cause more psychiatrists to be more wary of prescribing stimulants above the FDA recommended maximum doses? So, as Yogi Berra said, it's tough to make predictions, particularly about the future. So, again, particularly since there isn't a lot of logic. So the video I released, and I didn't say, there have been a couple well done studies, they're not complete answer to everything, that have not found any increased problems of substance abuse from telehealth prescribing, even people who are exclusively seen via telehealth. And there is compelling evidence that those individuals who preferentially are using telehealth or exclusively using telehealth are actually in high risk categories. So, more likely to have multiple medical problems, more likely to have multiple mental health problems, more likely to have had past substance abuse problems, more likely to be impoverished. So the restrictions are extremely likely to affect those most in need of care um, without clearly providing any benefit from studies or information we have to date. So I think, yes, almost certainly the more rules, restrictions you put on, the more people will be wary of prescribing or wary of crossing any lines or not clear of what the lines are. And it's going to be particularly, I think, those with less expertise who are general practitioners, just seeing a few patients, it will make some of those less likely or willing to work with any ADHD patients. And psychiatrists who are not quite familiar with ADHD, I think particularly that subset will be more reluctant to prescribe high doses. Again, I have a whole video on high doses. I don't think it's actually that useful of a concept. So I'm happy to bounce back to that. And I'm sorry for all the people around the rest of the world who might be tuning in, because this is a sort of a US specific issue, although often bad ideas from one country, sorry, and company get carried over into other corporations or jurisdictions. So Max says he was surprised to learn that the link between serotonin and depression is tenuous at best, if not non-existent. Why is it still propagated as fact, and how are SSRIs working if not on serotonin? So one is to sort of ask who's propagating as fact. I know Eli Lilly and some of the other SSRI manufacturers decades ago had advertisements which strongly implied, they didn't quite directly say, deficits of serotonin cause depression. So I do have a whole video on this. So what I would say is, from the very beginning, anyone who had half a brain in their head was well aware that serotonin deficits were not the primary cause of depression. And particularly because if they were, an SSRI should immediately resolve that problem and cure depression, which they don't. So we knew from the very beginning. So I would say what the situation is, serotonin is strongly implicated. Do we know the exact pathways or mechanisms? No. Does anyone know? As I frequently have said for 25 years, if I knew how antidepressants work, I would have a Nobel Prize, which I don't. But very clearly, serotonin reuptake inhibitors do work for depression, and they do work slowly and indirectly. So the claim is that messing with serotonin levels is serving as a signal to the brain and a signal to make new proteins, um, change how proteins get inserted into cell membranes and travel to different parts of the nerve cell membranes, which again in nerve cells can be centimeters away, a pretty huge distance for a tiny, tiny molecule, and probably even making new um, neurons. So again, nobody knows precisely how SSRIs work. Again, we do have studies showing if you block protein synthesis, then you block the antidepressant capabilities of SSRIs. But clearly, there are drugs that are norepinephrine reuptake inhibitors, and there are drugs that work on other pathways, such as ketamine drugs, whether those are working on glutamate systems or opioid systems or both together, it's not clear. But again, I would say serotonin is implicated. And I would say there's a whole industry, particularly in Britain, attacking the serotonin model. I mean, the bigger message is that antidepressants don't work at all, don't do anything for depression. All they do are emotional numbing mechanisms, but they are so they're weak, ineffective, meaningless drugs. But then they also claim they have extremely powerful, detrimental, damaging effects. Um, and most of their research is anecdotal research. So yes, you can find individuals who have trouble getting off of SSRIs. Yes, you can find people who have feeling emotionally numbed out, but very little of their claims are supported by good science there. So, hello, Dennis. So, Dennis says it does strike me that the proposed requirement for 50% of controlled prescriptions to be issued in person rather than telehealth would make 100% telehealth practice and the ability to prescribe any controlled substances incompatible. So, yes. And again, I mean, what's frustrating is the DEA has very explicitly said they are targeting a certain business model of these large telehealth companies. Part of why that's frustrating is that I'm blanking on the name. Cerebral was one of them, and Dunn Health or Dunn Global, two large multi-million dollar companies which were created in the last few years and are already essentially out of business because they were faced by multi-million dollar fines because they were accused of defrauding patients and because they were doing inadequate evaluations for ADHD and inadequate monitoring of and, and promoting stimulant prescriptions without adequate medical evaluations and follow up. So, again, we already have legal mechanisms in place to treat the bad actors. Um, we should be using rules or regulations to target inappropriate actions, not targeting actions that we know will cripple companies that have potentially doing bad things, because these regulations will also cripple plenty of other people because they are not clear at so far being no indication that they will be intelligently written. Um, Randall Taliban, don't have much to add beyond thanking me for covering these topics. Thanks. I'm glad you appreciate it and glad you signed in and hopefully sharing this with your friends, medical team, whoever might benefit from learning more. So Dylan asks, is it worth pursuing an autism diagnosis as an adult? I'm diagnosed with ADHD, but some clinicians have suggested autism while others have mentioned BPD, borderline personality disorder. I don't know what to trust. So I do have talks, and I've probably written more extensively about it on Medium about labels. And I would say labels or diagnoses are useful for three reasons in mental health as well as in physical health. They're useful for helping understand what's going on. And that can be both the treatment team's understanding and the individual experiencing it. So, for example, borderline personality disorder is considered a very pejorative diagnosis still. I do think it has some identifies a group of people in a meaningful way. And particularly, I've seen people where the diagnosis fit who felt finally, aha, other people are dealing with some of the same things I have, that there are known treatments which can be effective, that have provided great relief. So three reasons, I won't back up on this one. Three reasons for diagnosis. One is for understanding. Two is for prediction. And prediction is general prediction. It isn't, if you have depression, saying that you're going to be in bed on April 27th, too sad to get out of it, April 27th, 2036. So it's not precise, detailed, enough to buy the right lottery ticket or invest in Apple years before it blows up as a stock. These are general predictions of the likelihood of the course of the condition, the likely outcomes, the likely complicating medical or psychological or psychiatric or financial conditions. So, an accurate diagnosis helps us make general predictions. And three, it helps guide us to treatments that are appropriate. So, if you have the wrong diagnosis, if you think someone has bipolar disorder instead of borderline personality disorder, you might prescribe certain medications for them that aren't likely to work if the diagnosis is wrong. So the question is, if you've gotten into adulthood with an autism diagnosis, is it worth or without an autism diagnosis, but you are really somewhere on that spectrum? Can it be helpful to know that or have that confirmed? I would say I could see a scenario where there were certain social problems or if challenges or difficulties that finally make sense to you with that diagnosis, that might be useful. Um, so I could see it potentially being useful, but I can also see many people saying, you know, my ADHD is being adequately treated. Um, Whether there are additional factors isn't particularly providing additional use or meaning to me. So so I think so a third part of that l- label diagnosis issue, I would say I am a strong believer in trying to follow up as precisely and diagnose conditions as precisely as we can. On the other hand, I think people have the right to use the labels that are meaningful and useful to them, even when there may be discrepancies between what a medical expert and the individual are saying. So I've had some people who were comforted, and I do talk about this in the autism versus ADHD video. I have some people who I was convinced by every aspect of the description and their portrayal that they were describing social anxiety symptoms in conjunction with their ADHD rather than autism. But they felt comforted, validated by an autism diagnosis. So rather than trying to convince them that I was right, my assessment there was I will understand the person as I understand them, and they will understand themselves as they understand themselves, and there will be a discrepancy, at least at the language level, between the two. So Abdi Mohammed asks, how does Vyvanse compare to Adderall? So this is I think in my video on Vyvanse, but the absolutely consistent word that people use, and it's not just because I've suggested other people have used it, because often I don't suggest it. People describe Vyvanse as smooth, so its onset tends to be gradual. Um, for many people, both immediate release and sustained release forms of Adderall, when they're kicking in after 20, 40 minutes, whatever it is, feels somewhat jarring, feels revving up. That can be helpful for some people in signaling, aha, the medicine's here. It's working probably in other dimensions of my ADHD. And I've had some people where Vyvanse's smoothness was not helpful because they claimed they couldn't tell when it was working, or maybe it wasn't working. Um, Whether or not Vyvanse has lower risk for substance abuse, whether it has lower risk for psychosis, I don't think we have any data whatsoever to support those claims. Do we have basic science reasons or rationales where it could be possible? Yes. Um, so that's my quick summary as differences. There are certainly many people who do well on both. There are certainly people who prefer one or the other. I'd say in general, particularly if they can afford it, and now that Vyvanse has been generic, I have many more individuals, and I'm only working with adults who prefer Vyvanse to most Adderall immediate release or extended release products. James Alexander asks, is it possible to tell if a first time amphetamine induced psychotic episode is coming And how are the warning signs different from the anxiety, jitteriness, and other more common side effects? So, what I tell people when am prescribing amphetamines or any stimulant for the first time, when I give my warning about amphetamine induced psychosis, I say one of the most useful things you can do is to tell other important people in your life, whether it's your therapist, your partner, maybe a friend or coworker, because part of the delusional process. So usually there are mild suspicions, delusions, conspiracy thinking before it becomes more profound. But part of the whole delusional process is discounting reality and what others are telling you and accepting beliefs which aren't valid. So your own ability to know whether you're believing in a delusion is impaired by the delusional process itself. Um, Often there are signs of increased activity that isn't feeling anxious, it's feeling more empowering or positive. So even though the content of the delusional thoughts is usually someone else listening to the fears that people are spying on you, people are putting thoughts into your brain, people are manipulating you. Most people hearing it feel anxious. Often the people living it, experience it, are feeling a little more exhilarated than overtly anxious. I mean, that's my impression. Um, so decreased sleep, staying awake longer, and again, that's part of why many people call it mania, but I don't think it has some of the classic features of mania. Um, so I've only had one person who clearly was able to tell in the that, and maybe they were just being paranoid or suspicious, who felt that they were moving in that direction and stopped their use before it became full blown psychotic delusions. And that person, part of why they were vigilant is they came to me on 210 milligrams of Vyvanse and were on dosages in that range for more than 3 years before they had problems. So, one thing that I see commonly in discussions and literature and claims, and again, I don't know of any data or research to back it up, is that if you're going to get amphetamine induced psychosis, it happens right away. It can, but no, it frequently does not. Um, so that person, because of their high dose, was particularly vigilant, but they did start getting thought patterns. Particularly, they had dated only infrequently, and then became infatuated with an individual, and clearly started having thoughts and feelings that were delusional rather than infatuational delusion. Um, and stop their medication. So Max is sharing with Dylan the argument that unless a condition is negatively impacting your life, fishing for a diagnosis could do more harm than good, especially since misdiagnosis is so prevalent. I think there's some validity to that argument, but what I would argue back is that a condition like ADHD, literally millions of adults aren't aware that they have it. And therefore I mean, there's not just ADHD, but a whole host of mental health conditions where someone's awareness of the harmful effects it's having are are absent or blocked by their very condition. So they may be blaming everyone around them for being a narcissist. They may be blaming others for X, Y, or Z. They might think they're just accident prone or unlucky, that bad things keep happening because they're being inattentive. Or so so what's difficult, particularly in the mental health realm, is that someone can be having negative consequences, or the people around them can be having significant negative consequences, which they're not seeing the connection between their own behavior, thoughts, and feelings and what's going on. So that to me takes away a strong part of the argument that unless you're aware of how it's a condition is negatively affecting you, a diagnosis can be more harmful than good. Um, so Abdi Mohammed asks, is running daily concerning? I am going to start Vyvanse prescription. So as a runner, I'm interpreting this two different ways. So if you're meaning just taking Vyvanse daily, is that problematic? I would say we don't have any evidence that it is, and we don't have any evidence that taking weekend breaks or something else is preventive against any of the potential downsides of Vyvanse. So many prescribers are of the feeling that, again, ADHD doesn't just affect work performance or classroom performance, it also affects social interactions in the whole rest of your life. And medications tend to help with attentiveness, staying on track, not interrupting the whole gamut of executive functions that can be impairing social life as well as academic or career life. So, for that reason, if it's helpful for many people, it's helpful to take it every day. If this was a separate question about running and exercise and running every day concerning, um, I have my own fascinating story about breaking my kneecap through running every day. Um, but unless someone wants to hear about that, I won't go into that. So thanks, Max, for bringing up video on serotonin and depression. And KK asks, is magic mushrooms the way forward for ADHD? So I do have a talk on psilocybin that's a little dated now. It was when some of the first studies on alcohol addiction and depression were coming out. There are still, to my knowledge, absolutely no formal studies looking at psilocybin and ADHD. If you go on forums like Reddit, there are people expressing the feeling that it was helpful and others expressing the feeling that it didn't help them at all. And okay, Max is writing the proviso that he is not a medical professional. He doesn't even play one on TV. So just reporting what he's heard. And thanks, Max, for providing the video on psilocybin and mental health. So James Alexander is following up among your ADHD patients who've mostly resolved their symptoms with any sort of medication. Have you noticed greater professional ambitions or success in those on amphetamines? Um, Last Q&A, a study came up that found methylphenidate improved motivation more than modafinil. Does that hold for amphetamines versus methylphenidate and the other second, third line meds it clusters with? I'd say all these are really good questions. And I'd say, except for that study coming out of Brown University, which was designed specifically to try to tease apart cognitive, other executive function improvements versus motivation per se, I'm not aware. Most studies are not trying to tease the two apart. And in real life, human clinical experiences, it's often hard to know, is someone doing better in school because they're now more motivated and can see that there is some value in passing their history test, even though they think they're going to be a computer programmer. I'm coming up with examples off the top of my head. Motivation and cognitive and executive performance are intricately linked in feedback and affect each other, so it can be hard to sort out. I've certainly seen so my very first case of someone who had amphetamine-induced psychosis. And again, that happened 2 or 3 years into treatment. They were in their 40s, having finally gotten an ADHD diagnosis and good treatment, which reduced their symptoms, um, did change their professional ambitions. So they were able to finish college. They were all able to apply for and get a job that was much more challenging and lucrative, and were successful in that job for a year before they developed psychotic symptoms. So, yes, I've seen symptom reduction leading to changes in career trajectories and ambition. Um, sorry, there. So James Alexander's. Oh, sorry, I almost skipped a question by Max. So Max is saying they live in a country with a strong social safety net. Can I identify that it's France? Yeah, patients still struggle. How do Americans manage to get any kind of care with such bare bones insurance, if any at all, and no time off? One is, and I'll make direct comparisons, and I've only spent weeks at a time in France, so I'm not that intimately aware of the medical system, but I've read a moderate amount about approaches towards ADHD in France. As a, and this is again an overgeneralization, has lower tendency to recognize ADHD or to want to consider it a medical condition compared to several other European countries and the US. So one is that there may be a still inadequate but broader system or more receptive system to ADHD in particular in the US. Two is that since Obamacare, I mean, so even before Obamacare, we had Medi-Cal in California, Medicaid programs. So people who have low income automatically qualify for Medicaid. Yes, there's paperwork. Yes, Republicans have just added on more paperwork with the clear and express intention of kicking more people off the rolls, and reducing costs, even though all the evidence indicates getting people better healthcare reduces societal costs. Um, so, so beyond Medicaid, which is there for the poorest of the poor, many people who were working poor didn't qualify for that. They were too rich for that and too poor for insurance. So when Obamacare went into effect, and that's about 10 plus years ago, I don't have the numbers at the top of my head, that provided affordable insurance for many more people outside of the formal private insurance system, which is mostly tied to people's work. So there are millions of people who weren't covered before and now have coverage. And I mean, what we call bare bones are not, I mean, our whole system is in disrepair. So my husband was a federal employee, and he got in the era of some of the best benefits people could ever have. So he has really good health insurance, which I am on now. I wasn't allowed to be on it till we were allowed to be officially married. Um, Other social issue there. But I'm in a rural part of Hawaii. So I damaged my ankle in October last year running in a race. It took until February to get an MRI. It took until May to see an orthopedic doctor, and there still hasn't been any treatment. And I'm a doctor who knows how to assert myself, at least sometimes, and savvy with the medical system. So insurance is a problem. It does create disparities, but even good insurance in many parts of our country is the blocker barrier isn't insurance only insurance anymore. It's as much what providers are available and how overworked they are, and yes, they're being overworked and undervalued is a byproduct of the insurance industry. So that's a complicated question. I'm not sure if I answered it in a meaningful way, and those are my opinions, but I think they are well supported both by anecdote and fact. So James Alexander asks, how effective are newer antidepressants other than atomoxetine and viloxazine, like Cymbalta or Effexor for ADHD compared to tricyclic antidepressants in respect to symptom resolution, not tolerability? So one thing that's really challenging is making head-to-head comparisons. So why I mean, one is there's very few studies that look at a placebo, look at someone on Cymbalta, look at someone on nortriptyline, and look at someone on methylphenidate. Um, and even if you do that, then the study can be highly biased just by what dosage or what range of dosages you're willing to look like. So you can stack the deck. So, you have a comparison between Strattera and Qelbree that looks like everyone favors Qelbree because the Strattera doses were too low or were titrated up too quickly or X, Y, or Z. So even if you do head-to-head comparisons, which there are extremely few of, those can be tremendously biased by dosing schedules and how they were set up. And if you're not doing a head-to-head comparison, then there are questions of, were you looking at similar populations, or did this one have more females? Does this one have more people who also had comorbid depression? Was this done 20 years earlier when belief in the placebo effect had permeated, expectations were different. I mean, we know placebo rates have gone up generation after generation in both depression and ADHD studies. So looking at most of the studies on tricyclics were decades ago, and most of the ones on the newer antidepressants are more recent. So in general, studies that try to look at effect size, and again, effect size will be biased by what population are you specifically looking at? What measures are you using to look at performance? So they fall in the same general range, and I would say that there isn't any clear-cut distinction in terms of efficacy. In terms of tolerability and risk, the tricyclics, and I know you didn't ask me to go into this, the tricyclics tend to have many more side effects. Most people have at least some side effects. They can be what the medical people call trivial, like constipation and orthostatic hypotension, so dizziness when you get up too quickly, or they can be more dangerous, like cardiac arrhythmias. Um, so again, the tricyclics are fairly effective way to kill yourself an overdose. The SSRIs or SNRIs are remarkably inefficient in that regard. So thank you, Max, for providing the link to the video on autism and ADHD and the video on Vyvanse. And the zapping dissident, what do you think of dopamine releasing agents versus reuptake inhibitors? Um, so I'm not sure if you're, so some of this I discuss in whether Ritalin methylphenidate is really a stimulant. So amphetamines pretty clearly have both reuptake action, inhibit reuptake of dopamine and norepinephrine, and they cause extra amounts of dopamine to be released from synaptic vesicles. And many of our non-stimulants, such as bupropion or atomoxetine or others, are having effects on reuptake, and no current evidence of causing extra dopamine release. And the evidence for methylphenidate Ritalin is kind of mixed. It clearly is not nearly as potent at causing extravesicular release, and there's some studies showing it's more rearranging the location of vesicles rather than causing extra to be content to be released. Um, I think overwhelmingly the data indicate greater efficacy for dopamine releasing agents in terms of reduction of ADHD symptoms. And by and large, that's what people I've worked with observe, that they get more robust effects. Now, there's clearly some individuals who do get better effects from methylphenidate or bupropion than from amphetamine. Again, there are different side effect risks, but in terms of efficacy, that's what I would say. James Alexander asks, what are the typical reasons patients with ADHD who aren't aware or suspect they have it come to you in the first place? So one is, I've also not taking any new patients since moving to Hawaii 3 years ago. So this is maybe more historical, and maybe as awareness keeps growing, there'll be fewer and fewer. Um, I'd say the commonest scenarios were anger management and or substance abuse, lack of being able to control, not necessarily being so strung out they were missing work, but knowing that they were having trouble controlling their impulses to restrict use of certain products or behaviors. Um, I've also had large numbers of people historically who thought that they were only dealing with depression and were again in the mental health system for years or even on disability for years, where the ADHD component, I think in many of these cases was not just there first, but there was causative in all of their others and had been completely missed or ignored. So I've certainly seen both anxiety spectrum and classic depression that comorbid with ADHD, that the ADHD had not been addressed or aware of. Um, I also have a handful of people, maybe generationally distinct, so my age or older, 60s or older, who have severe, robust ADHD symptoms, but because they think they know what ADHD looks like in others and don't see themselves as intruding on his other space or is disorganized or other features are have been adamant that ADHD isn't what explains them, even though it, it fits them classically. So I don't know if that answered the question. So Abdi Muhammad asks the question about whether someone can keep exercising when they're on stimulants. So, on average, with Vyvanse, there is a 1 or 2 point increase in heart rate. There's a 2 to 5 point increase in systolic blood pressure. That isn't dangerous. I mean, there are some individuals who have a bigger effect than the group average. Um, there's overwhelming evidence that running and is good for mental health, including for ADHD. So I would strongly encourage continuing to run. Um, and I've had people who became more hypersensitive to rapid heart rate or sensations in their chest, which all of these individuals had extensive workups, which didn't reveal any difficulty or challenge. And I think in several of the cases, the concern is that by becoming over concerned and checking their heart rate monitor and checking their heart rate all the time, they were actually tapping into sympathetic overdrive and making it more likely that these variables would be elevated. Um, so I have 10 minutes left. James Alexander wants to hear the kneecap story. So I'll try to give it without too much over back. So I was a marathon runner. I run 99 marathons before I turned 50. And then I had some back injuries, and it took, I assumed, so the back injury caused atrophy of my left quad and problems there, but I had had some other injuries over the years. I figured I'd still be back running marathons and get my 100th within a year or two. In addition to running marathons, 3 seasons, I coached people in a fundraising program. So I taught hundreds of people at the beginning level how to ramp up from, these were complete non runners, to go from 3 miles to 26 miles in the course of 6 months of training. So it wasn't I was being over aggressive. So I kept having different problems every few months that would set me back to 0 miles an hour. And at the same time, I had a friend who did not take up long distance running until he was in his mid 60s. And then he got interested in this program that had people run every day. And he had a streak of, I think, 2.5 years of running every single day. So I decided that maybe if, and up until that time, I had never run more than 4 times a week, believing you need to give your body rest and recovery time. So I decided maybe if I were running every day, I would get feedback more quickly from my body of what I might be doing differently or wrong with my pace, and be able to adjust it and head off any more severe injury accident. So whichever year it was, I started January 1st. I did a 3 mile run every single morning. And on the weekend, I started at 3 miles and increased by 1 mile a week. So my long run started 3 miles, same initially, and then went to 4. So by the end of April, I had my long run was up to 17 miles, still doing the 3 mile every single day. And Tuesday, last week of April, I think it was, I was doing my 3 mile run, and I would run before dawn early morning. And for whatever reason, I've also had breathing problems. I was running about a half minute a mile faster, which is not an insignificant difference when I've been very steady. So something about my pace was different, and now it's pounding. But I go back up. I was not having any inkling of pain or problem anywhere. So running my 3 mile run, I am at 2.95 miles at the very end of my block, just about to turn the corner. And I had sharp stabbing pains in my left knee, and figured I have to get home anyway. I might as well keep running. So I took about 10 more steps and heard a loud crack, like cracking your knuckle, but it was like a knee sized knuckle cracking. And there was actually an abrupt diminution in pain, decrease in pain, didn't go away completely. So I limped the rest of the way home and went to see the knee doctor, whose name was Dr. Dye. There's more stories there. This is one of my favorite stories. And had split my patella. So, and it was a stress fracture. I mean, it essentially is a stress fracture since I didn't fall, I didn't hit it, but the two pieces were, had several millimeters separation in the two halves because it was along the long axis of the leg. They don't pin it, or there's nothing they can do. If it had been horizontally, then they'd have to, because the two tendons would be pulling it apart. But since then, I have not recommended that anyone run every single day unless it works for your body. So there's my story. Maybe it is a mental health story in disguise, but I like to think not. I still don't have any explanation for how or why that happened. Again, I was trying to scan my body. There was no preliminary mild knee ache leading up to that. Um, if you have a good explanation, no one else has been able to offer me one, and that was back in 2014, 15, decade ago. So Max asks, have I read or heard anything about Professor Nasser Daemi and his criticism of ADHD as a diagnosis, and specifically adult ADHD, which he believes is pushed by drug companies to sell more drugs? So he used to be a contributing editor writer for one of the monthly, um, not peer-reviewed psychiatric articles, but a monthly sort of review articles, and clinical tips. I think it was Psychiatric Annals. So I've read a fair amount of his commentary. I mean, he's made his reputation as a contrarian. He likes to attack flaws or weaknesses in our field, and I think many of his criticisms are accurate and right on. The About a year and a half ago, by my recollection, maybe it's longer now, he wrote an article on ADHD, and it was essentially claiming that everyone with ADHD, that it's just an affective disorder, which is his specialty, meaning some form of depression. And it was just so completely nonsensical and made it seem like he's never dealt with an adult with ADHD or seen it. Um, I mean, have the drug companies increased awareness of ADHD? Absolutely. But again, the very fact that there are people walking around robustly with ADHD who aren't aware of their ADHD, their existence wasn't created by drug companies, and the recognition that the pattern of their symptoms does not fit any anxiety disorder, does not fit any affective mood depression disorder, does not fit autism, does not fit anything else except an ADHD pattern, to me refutes another big chunk of his argument there. And I'm looking, so I'll try to wrap things up. And I see there's several questions by James. So maybe some of them might wait till next time or continue. James asks, Alexander, have your ADHD patients' family environments ever impaired their treatment or aggravated their symptoms? What were some productive and unproductive ways your patients handled such environments? I mean, I think particularly since I'm not wasn't a child psychiatrist, there very clearly often parents with ADHD, some many provide wonderful, loving environments, but some introduce elements of chaos, uncertainty, lack of structure, and consistency. Um, so I've had lots of patients who talk about regrets of their childhood environment. Um, I've very often had patients trying to have conversations with their adult patients, with their very adult parents about the parents having ADHD and whether the parent can ever accept or conclude that. Um, so I'll sort of stop there because there's a lot I could go into, but we're running low on time. So Sean is taking 300 milligrams of Wellbutrin XL daily. It helps with mood and motivation, but it's not as much with focus. Is it okay to add a low dose of Strattera, maybe 10 or 20 milligrams? So again, I can't make specific recommendations. They have long-acting doses of bupropion as big as 450 in a single dose. So my usual strategy is to get the most out of a single drug before augmenting or complicating it with another. So there may be possibilities to increase staying with the one drug. But I've certainly seen, and other people have treated people on a combination of Strattera and Wellbutrin. And yes, I would go slowly and sort of observe what you're seeing. And again, some of the effects of Strattera may be immediate, and there may be some additional benefit after weeks on it. So thanks, Masks, for providing the stimulants and cardiovascular link. Um, oh, and James Alexander had a message which Max answered, so I don't know what it was. So so I can't comment on it because it looks message retracted. But Max was providing reassurance that it's a normal human experience, just much more frequent in those with ADHD. Um, so again, that emphasizes, and part of the struggle with Dr. Gamey and others is that there is no pathognomonic um, symptom of ADHD. There's no symptom that clearly, distinctly identifies ADHD. All the symptoms of ADHD are normal human behavior. They're just happening at greater frequency and often in situations or to an extent that isn't happening to others. Yeah, so I'd say if we're calling it sort of second guessing yourself or internal dialogue, I'd say I'm thinking of Frank, the individual who I very first worked with, and he would be second guessing himself many of the same incidences I heard about dozens, scores of times, many of them events that had happened 50 years ago, as well as what had happened on the way to the office and why he was late and why he had stopped to talk to the guy with cool cowboy boots and told the guy he was already late for the appointment but couldn't pull himself away, and then was second guessing why, even though he knew he had ADHD and he knew he had the tendency to do this, he couldn't rein himself in. So internal dialogue and actually making internal dialogue external. So in the days before everyone was on a cell phone and talking out loud seemingly to yourself became normalized because you were ostensibly on a phone. Um, Sharing your internal dialogue out loud is actually substantially more common in ADHD than the general population. So thanks for the great questions. Thanks for showing up. Thanks for watching the videos. And I will be back next week. Stay healthy, stay happy. And if you think we're in a crazy world, that's a sign of mental health.